Hi, everyone. Welcome back to the Resilient Aging Unfiltered podcast. Today, I'm so excited to welcome Dr. Chhaya Makhija. She's triple board certified in diabetes, endocrinology, and metabolism and lifestyle medicine. And she's the founder of Unified Endocrine and Diabetes Care. She has a unique approach that's really impacting patients positively, a comprehensive, holistic approach, which I really resonate with. And so, welcome, Dr. Makhija.
Thank you. Thank you, Dr. Cabral. It's an honor, and I am very much reciprocating as to what you do and what your mission is, since I've learned so much about you in the recent past. So thank you for having me.
Thank you. Thanks for being here. And so, of course, I do want to say thank you. You had me on your
Mhm.
podcast, Hormones and Hope, recently, and that was amazing. I loved our conversation, and a lot of some of the themes probably will come up today, but from your perspective and your unique life experiences and approach. So maybe you can share with us, how did you end up getting into
Mm.
the fields that you're in?
Yes, that's $1 million question, right? So I'll answer this in a very similar manner that when my medical students ask me. So, I'm born and raised in India. So, and I'm almost 45. So at that time, the era is changing. If you're born in an Indian family, you either become a doctor or an engineer.
Hmm.
So my siblings are engineers. I'm the physician. But truly speaking, it's, as much as I know myself and remember the earliest memories, I also always wanted to become a physician. The specialties, which is internal medicine or the endocrinology or diabetes, endocrine and metabolism, is inspired more with seeing my grandma who was struggling with diabetes, with amputation, while I was
Oh, wow.
around 8 to 10 years of age between that duration and then the demise because of complications. And I've witnessed, my father's personal journey with multiple myeloma and how that was affecting the bones. My mother's history of Graves' disease, which is hyperthyroidism at an early age, and witnessing the severe cases, which really, really was like one of the important reasons that I got interested in diabetology, endocrinology, and pursued that further when I moved to US after my medical school. So that's internal medicine. The fellowship
Yes.
is endocrinology. And the third one is lifestyle medicine. That's a new field. And the reason to adapt or, get to that certification, I would say was just for my learning because I grew up in India. There was a lot of background and upbringing which relied on your family connections, bonding, your spiritual goals. There's nothing
Mm.
religion, but neither faith, but spirituality in terms of who am I and what's my purpose at a younger age, which you don't care about, or at least I didn't care about at that age. But it was ingrained in me. Yoga, mindfulness, eating together on a table, and being with each other in terms of conversing every day, sleeping at the same time, getting up at the same time, very timely habits of eating home cooked foods. So all that I did not cherish while growing up because at least teenager years, you're rebellious. At least I was. But all this became so ingrained in my DNA that after doing endocrinology, I felt like that part is missing in medicine. When I'm conversing with patients, because really started loving prevention rather than disease management when I started practicing endocrinology in, almost more than a decade ago. So that shifted me to learn the evidence-based science in regards to what I grew up with. So other than nutrition and activity, also what's your social connection and how is that helping you with stress management? How is it helping you with coping stress? Why is your sleep so important other than in prevention, like just for your health? And health is emotional, psychological, that mental well-being rather than just a physical parameter that we look at in blood work. So it resonated with me so much that I decided to just pursue an official certification. And I don't see a need that every physician needs that certification, but because it gave me that background of re-emphasizing that how much evidence there is and how much proof we have that lifestyle interventions work in a setting where you are supporting your patients. So that led me to the triple board certification and where I am today in terms of practicing patient care, education, and even the podcast.
Right. And you do teaching as well, right? Medical students.
Right. That's yeah, I can never leave that.
Yeah. Yeah, that's so important.
And they're a big part. Students are the ones who inspired me to start the podcast.
Oh.
My pre-med students who work with me, they came up with the name Hormones and Hope.
Mhm.
I didn't have to do anything. And I literally just sent out a poll that, okay, please pick to my physician colleagues, and they decided to pick the name. And they are the ones who've been helping me with lots of handouts that we've been creating for the community and for physicians in the world of diabetes, osteoporosis, metabolic health, GLP-1, thyroid, and so on. Yeah. So they're a
That's
big
wonderful.
part of what I'm doing today.
Yeah, and that's a nice, example of an intergenerational experience.
Mhm.
And they're so good with doing design and making things pretty for, social media. That's great that you have them. That's wonderful. What a great
Yes, and
idea.
it makes us feel younger. I think that would also lead to your specialty. There is a
Mhm.
selfish desire of me feeling younger mentally when I'm surrounded by them because
Yeah.
I learned so much.
Right, and they're obviously getting so much from being around you too in so many ways, so that's wonderful. Let's talk more about your practice that you created and integrate all of these things then. I'd love to hear about what your model is and your process and how patients go through and you bring in all of these different things and this different expertise you have.
Sure, Dr. Cabral, that's very personal because it's like my extended family.
Mm,
So I've been practicing traditional. When we call traditional or conventional medicine is, we have a patient is connected to, or buying some health insurance. The health insurance decides which physician they're going to see. The physician also has to be contracted with the insurance, or the physician is working for a hospital or a corporate institution. So there are so many layers between the decision making of the physician needs to see the patient or the patient needs to see the specific physician or healthcare professional. So I've practiced in that world for more than 12, 13 years. And there was a big gap, which many of us as physicians have felt. Some have
mhm,
gone through the route of burnout. But from a patient's perspective, I really felt the pain at several occasions, several experiences. I had one patient, she came out, and I was employed at all those times. Came up like, I have thyroid cancer. Dr. Makhija discovered the nodule, but she's not doing anything. My CAT scan and CT scan is pending. No one's taking care of it. And this is within a span of 48, 72 hours. I don't get that message that the patient needed something called as prior authorization, that is medical necessity form to approve the CT scan as per insurance policies. That never came to my desk or in my message. So the patient literally yelled at me really loud, and it was heartbreaking for me. And that was like Christmas Eve, and we were getting ready for office Christmas party, and I really felt her pain. I was like, I couldn't even say sorry. I was just numb. I said, I can understand that she is dealing with this diagnosis, and I helped her making this diagnosis, and something is that I'm unaware of what's happening in between, but I put in the order, so it's my responsibility. And the next few days it's going to be off since it's the holiday time.
mm,
Can't do anything, right? I can't pick up a
mm,
phone and figure this
right.
out anymore. I don't have any staff who's going to work on it. The other imaging center doesn't have any staff, that they're closed.
Mhm.
It wasn't urgent by any means, but her frustration that no one got back to her as to what's going on. So I had a few similar experiences where I felt helpless. And there were times where, I really wanted to take care of patients with diabetes because I knew I could help them. But the structure in corporate world was such that diabetes takes the longest time. So physicians will not be seeing diabetes patients anymore. The mid-level, that is called nurse practitioners or physician assistants, will be taking care of these patients. Why? Physicians need to see more patients because they will be provided 15 minutes. So now I'm bombarded with cases of thyroid nodules, ultrasounds, because they take less time apparently as per the corporate world. So those were, several experiences which led me to decide this, I had one other podcast where someone said that, the wheel is spinning, but you let the wheel stop spinning or just slow down, and that's where you can get answers. So
Mm,
pandemic 2020 was was a time where we had less patients. We were not able to see as many patients, which led me to look into what else can I do in terms of changing on how I practice and how can I take care of patients way better in a timely manner where they're directly communicating with me. And I had learned about direct primary care physicians. And if your audience is hearing, we almost have more than 10,000 physicians through the nation in the United States who are practicing a different type of a healthcare system, which is direct primary care, where the physician is just having a direct agreement with the patient. And everything else in terms of their orders, labs, medications are still going through their health insurance. But that allows the patient and the physician to spend as much time as they would want to get better, focus on prevention, focus on their actual health, which is that comprehensive holistic health, and also help them, debunk these myths, misinformation, guide them, help them navigate, be there for them, support them, and also advocate for them in this chaotic healthcare system. And that is direct primary care, and that the direct specialty care, that is specialists like you, myself. There's rheumatology who got this inspiration of founding direct specialty care, similar way of taking care of your patients, but it's also grounded with that time, trust, transformation, accessibility, so that your patients get more than just 5, 7 minutes of your discussion or just a prescription, and that's about it. So that's direct specialty care. And I founded it in 2021. Had no idea how this was going to be done, but you always have this gut feeling to follow your passion, to follow your purpose. And my purpose was, how can I give the fullest in regards to not just the expertise, but the time, the heart, the listening, my ear to my patients, my heart to my patients fully. And if I'm happy internally, spiritually, I can always give the best to person A, B, C, or whoever comes in front of me, just as a human being. Right. So that led to this direct specialty model, and I call it as unified endocrine and diabetes care, because unified, so it's unifying the concepts of the traditional art of medicine, which is patient-physician relationship, and adding the time aspect of it, adding the knowledge, evidence-based science, so that you're merging both of these fields of medicine.
That's beautiful.
So I would say thank you to patients.
I just wanted to mention when you shared that story about your patient who had that cancer situation and you felt helpless and she felt helpless, and it's so sad that this is becoming increasingly common.
Mhm.
And of course, I can understand and relate to your need for autonomy and in order to give all that you have to offer. So, can you talk about your in terms of your visits, how those are structured, and is it people come in as needed, or there's like a set pace to how they're coming in, or it just depends on what their situation is, I guess?
Sure, yes. I let the patients decide. So to make it simple. So I have, my practice is in California. So anyone residing in California, I'm able to give them that type of care. And from the practice perspective, they decide if they need to see an endocrinologist for any symptoms. So,
Mhm.
as opposed to traditional care, you don't need any referral. And many of them may just need a second opinion, or they need help to connect the dots or solve some jigsaw puzzle of their health, where chronology is the specialty which can most likely help answer those questions. So it could be a one-time visit, but it's elaborate, so 60 to 90 minutes.
Mhm.
I review 60 to 90 minutes is face to face, be it telemedicine or in person. But prior to that, I review all their records. My staff is mostly nurses or pre-med students. So they are well versed with making sure that all the records that I would need to help my patient are present before I see the patient. And after we are done, so other than the clinic evaluation, if I need to do anything in terms of ordering or guiding them through lifestyle interventions, what medications that might be necessary versus can we just have a discussion, and then just showing them the journey of, is it possible, and giving them the right hope rather than just one visit, and then they decide if they would want to continue care with me, or they got all their answers and now they would be working on their health. So since my specialty involves a lot of chronic conditions. They already had complicated diabetes, or they're struggling with trying to get their thyroid hormone levels in control, obesity, all the metabolic conditions, including osteoporosis. Many patients become a part of the practice, which is called membership. But membership doesn't mean that they're getting care from anyone else. It is still the physician, that's me. And it's basically unlimited Q&As. Every resource, every question is handled by me. And it's like having an accountability partner, a support, a guide, a mentor, a coach. So, for example, today I had a patient with starting hormone replacement therapy after sitting down with me 3 times. So, 3 separate visits, so that she could feel confident that she's read everything, she's got all her questions answered, as well as reading through the data, the evidence, which I provide to them, simplifying it, like what are the risk versus benefits. Once those questions are resolved, which took almost a month for her to go back and forth, she started it. And then I have them, send me a FYI. Just let me know that when you started. Okay, how are you feeling after 1 week? How are you feeling after 2 weeks? What are we doing with your strength training? What are we doing with the nutrition? They would sit down with my dietitian to work on things that I have recommended. What are you doing in terms of your sleep? Okay, how are you engaging in conversation with your family, or how are you dealing with work? This is all included in medical care. And that's why it's termed as membership. But every interaction is still with the physician rather than, 10 different providers, or their message could be lost in traditional care. It doesn't, because they're all being addressed to me. So it's a love letter from my patient to me whenever they would want to, in terms of questions, any events or incidences happening, anything else in their health, which may not be related to endocrinology or the care they're getting with me, but indirectly it might be. It might be causing them to not sleep, or it might be leading to a lot of stress, which is probably affecting their blood sugars, or they're affecting their mood. And then I can help them tweak from my end what's needed to be tweaked. Or it could just be a counseling session that I hear you and I'm with you. Let's have some patience. Let the time heal, and we'll get back to this maybe in a couple of weeks. So that's the part of medical care, and that's why I called it as extended family, where there is transformation happening. We don't wait 3 months to get a blood work done to figure out have we improved or not. The improvement is happening almost every day, and there is weekly accountability between the patient and even me. And if I don't hear from them, they'll hear, "Hi, Jocelyn, just checking in. How are you doing?"
Amazing. Tell me about the feedback you get from your patients. This sounds like heaven.
It is. I would want such care if I'm dealing with any form of, illness that is relevant to endocrinology, but also in terms of prevention. So many of them will see me because they've had family history of prediabetes, diabetes, metabolic conditions, or they're concerned about their risk for developing these diseases and how they can prevent. So a lot of preventive consultations. I would thank my patients for their love. We have 4.9 stars, more than 100 Google reviews, testimonials. My patients sit down with me and they've recorded their testimonials, which are on YouTube. And they've been so generous in sharing their journeys of type 1 diabetes, type 2 diabetes, one of them with not losing the foot in regards to amputation. The other one dealing with diabetes for more than a decade with blood sugars of greater than 300, 400, and not realize that it was impacting his health. And how he feels today. He's running a marathon, which he never expected because he was worried about his amputation. So there are stories that they are willing to come and speak about, share out in the world. And that's all the love that I can express in terms of sharing or answering your question.
I should have asked you earlier. It would be helpful if you could define for the listeners, for people who don't know, what is endocrinology?
Yes, so study of hormones. And hormones are not just estrogen, progesterone in female and testosterone in male, but we have hundreds of those, many of which we cannot sustain our life without. So there is cortisol, which is commonly known as stress hormone. Can't live without that hormone. Thyroid is the next one. If we don't have enough thyroid hormone or it's absent, we can't live a sustained life. And the third one is insulin. And that's where diabetes comes into our specialty as well. Again, we cannot sustain life without insulin. So these three hormones are just essential for our life, like in terms of sustenance of life, without which we cannot survive. And then we have powerhouse in our brain. So that relates to your world, Dr. Cabral. Hypothalamus and pituitary, they're these tiny, tiny glands, all smaller than a pea size, and they govern all our hormones in below the neck. So thyroid, adrenal glands, our even our gut. Muscle is an endocrine organ which produces the hormone which helps us with anti-inflammatory action, so against the inflammation. And how we grow, that's important. We have growth hormone. How we respond to stress, that fight and flight response, is endocrine. There is something called as autonomic nervous system, where you call it as a rest and digest system and fight and flight response, but these are all hormones which are governing how we respond to situations. And the last piece in endocrinology, the study of hormones, is also bone and metabolism. So, how our engine works, since hormones are messengers, every cell is cross talking with the other cell. So, that is all in the endocrinology world. And osteoporosis, osteopenia. Audience, I would want to highlight that vitamin D is not a vitamin, it's an actual hormone, and that comes in our specialty, and how it influences your calcium reserves, your phosphorus, your bone health. And there are other aspects of vitamin D in the immunity world that we are learning more and more about. So all that encompasses the specialty. So it's pretty much top to bottom,
Yeah.
influencing both internal and external environment for us as humans.
Thank you. That was beautifully stated. Um, Now, this podcast is called Resilient Aging
Mhm.
Unfiltered. So we love to learn about things we can do as we're getting older to stay resilient and vital and full of life energy. Can you talk about what, say, for someone that doesn't have yet diagnosis of diabetes or thyroid disorder, like what are just normal things that happen to us with our hormones as we age and with the endocrine system?
Yes. So I'll start with, because your podcast is resilience or resilient aging, and how this world or this specialty fits into that. Resilience is, how we adapt and cope with stressors, surgery, trauma, and it doesn't happen at that moment, right? So it's built. It's like a muscle that is being built over the years. So if there are 20-year-olds, 30-year-olds, 40-year-olds, 50-year-olds, 60-year-olds, you all have the capacity to develop that muscle now, today. In the hormonal world. Now, with your specialty, Dr. Cabral, we all know that there are these metabolic conditions, specifically obesity is excessive weight, as well as diabetes, specifically type 2 diabetes mellitus, as largest contributors for the risk of dementia in general, risk of stroke, risk of heart disease, and they being in the top 5 for our mortality. Individuals realizing that and being aware of it will probably look at their risk factors, which is also our ethnicity, it is also our family history, and it is our environmental factors. What am I eating? What am I thinking? How is my sleep? How stressed I could be related to just our normal routine, work, personal life, versus the other stressors which life throws at us. All those are also impacting us with where we are thinking about the aging aspect of this human journey that we have in the endocrine world. So there are a lot of changes happening. All of us, I'm seeing younger and younger patients with type 2 diabetes mellitus. So my youngest is 15-year-old. I am an adult endocrinologist, and the norm that we had, that diabetes is an age-related problem, is not anymore. We are seeing younger and younger individuals with this condition. So just based on that, the trajectory of having a younger human being with heart disease, a younger human being with dementia, a younger human being dealing with stroke because they're getting diagnosed with these conditions, obesity and type 2 diabetes mellitus early on, is pretty high. That the risk is pretty high. I don't know if you're seeing that shift because it's still early since we are diagnosing these individuals now in their teens and in their 20s. So that for someone who is either dealing with in your young adulthood or who has a risk factor, I think it's very important to add on to that knowledge and awareness so that you can take those steps today with your healthcare professional or with your healthcare provider. There are a lot of changes happening in our hormones too. So for women, right, we have this phase which is called reproductive phase where we make as many ovaries and I mean eggs, and we have adequate estrogen, progesterone, and then comes something called as perimenopause and menopause, which is in simple words, decline of estrogen, progesterone to negligible amounts and almost zero by the time it's that menopause and postmenopausal phase. We have enough evidence that how it affects our mental health. It also affects how our memory is. And in common terms, it is also called as brain fog. And me being 45, I've experienced those snippets in my life in the last, I would say, 6 months, and feels like, oh my gosh, this is real. My patients are talking about real symptoms and how that can impact our memory, our aging, is also now, way more in evidence and science as compared to 2, 3 decades ago. So approaching these things in terms of with more power and strength and knowledge would help us to tackle it early on. So as I am getting into this age of 35, 40 as a human adult, right? What can I do in terms of just knowing what's happening in the body, and if it is recognizing it, do I need to address it with lifestyle interventions by again getting the right resources, right expertise, versus do I need to seek medical expertise? What are the solutions? Is there hormone replacement therapy? Just I was sharing that in the earlier discussion, that ask questions, get that Q&A, but read and listen to the right resources. So like your podcast, you're giving amazing information about the prevention as well as the treatment for dementia and Alzheimer's, for all these neurodegenerative diseases. So seek out those platforms rather than any random influencer, which doesn't have any expertise, true medical expertise with backing up with science. So when physicians like yourself, and that's also my mission, that I would advise or share any knowledge that would be applicable to me or my family. So I'm not going to get any form of misinformation or any form of discussion out in the world that cannot be implemented or cannot be discussed with me or my family for their health concerns, right? So that will also help the individuals cut out that noise and really target to their specific concerns. In men, the same thing is happening. In general, testosterone declines as we age. Now, the good thing is that it doesn't drop down to zero like in females. So females should be aware that there is a remedy. We have hormone replacement therapy bound to be very, very safe. We have other non-hormonal therapies that can help you, which will also help you live with that, like you talked about, vitality, the strength, the power. And one of the menopause specialists that I interviewed recently, she says, I tell my women patients that you've crossed your reproductive life. Now, in the real sense, you are going to be productive. So knowing that there is a beautiful life after a certain age, because your mental perspective has to change. What's available out there, you learn about it, and there's not just hope, but reality, the world of science, that we could live the bestest of the best life when we are aware and we have that knowledge and we're able to implement in a personalized way with the right physician. So in men, them testosterone does not decline to zero, but there is this age-related decline, and not just going to the physician to check your testosterone just because you heard about this, but also recognizing what else can impact. The same thing, obesity, diagnose sleep apnea, and control meters, stress, insomnia, not sleeping well, worrying about things over and over again, or untreated depression, anxiety can all impact your testosterone. 'Cause it's being governed by the powerhouse that I talked about, hypothalamus and pituitary. So it's important to address that before you decide to just go on, testosterone injections, which we are fading away from because we have better solutions for our patients. Again, legit FDA approved medications. So not treating these conditions is impacting how we age, is impacting our health, our brain health. Not treating deficiencies or not identifying, not screening them is going to impact on how we think. Not addressing depression, anxiety is also going to address our as how we age and how we cope with health challenges that may come about, right? The last thing I also wanted to specify, because it comes in endocrinology world, is our muscle and bone health. Like how important it is. I've learned I would say in the last 12 years of my life, and in terms of personal experience, but muscle is an important organ because it releases those compounds, hormones, which are anti-inflammatory. Muscles help you reduce your risk of diabetes if you are gaining enough strength. I'm not talking about bulking up. I'm talking about being flexible. I'm talking about the power, the strength that you can have, and also looking at bones because we all, again, have this loss of bone density with aging. We have loss of muscle mass with aging. We cannot reverse the bone aging as such because there is around 1 to 2% loss every year, and especially after age 50, more in women, more profound or more impactful in women than men.
Can I hop on that?
Yes.
You saying that cannot be reversed?
Yes. So the aging, as the aging decline, the age related decline of bone density is not reversible, right? So say I am aged 80, I cannot have the 20-year-old or 30-year-old bone mass. But so the age-related decline is happening, but there are other factors that are worsening the decline. So that is related to our hormones. So estrogen, progesterone, poor muscle mass will lead to more profound decline. It will also be equally explainable in men. If they have low testosterone, it's going to impact their bone mass. Diabetes mellitus is a risk factor for low bone density. There are certain conditions like rheumatoid arthritis, which lead to low bone density. Smoking, notorious to cause low bone density. Our males and females are, more and more getting diagnosed with eating disorders, right? So that's
Are they? I didn't realize that.
a lot. I have, and it's in conversations that I'm trying to look at, and lo and behold, I start getting suspicious, and then I have them get evaluated, and so many of them, and guys too, like young teenagers. So that's impacting their bone density. So that is worsening the age-related changes. Now, because you questioned the aging, so we all are born with a certain bone mass, and by the age of 2022, we achieve our peak bone mass. After that, there is this gradual decline, which is very small in percentage. And then after age 50, 60, it goes up to 1 to 2% per year. But if we start with healthier bones, the decline may not lead to osteoporosis. The thinner the bones are, where we start at age 20, 25, the sooner we get into this osteoporosis zone or the low bone density zone, because where we started was very low. So 20-year-olds, 30-year-olds, they don't necessarily have to think or worry about it, but just being more proactive at your bone and muscle health are equally important. And engaging in physical activity, in movement, no matter how busy you are, it's very possible.
Really fascinating. And I thought of too that the studies that show that if you are thinking about your muscles that you're using when you're doing specific exercise, or you're thinking intentionally that your activities are like exercise you do, those have greater benefits for your BMI and your muscle building, your toning. So if you are 20 and 30 and you are at least aware of that, then when you are exercising, maybe that has an even more of an impact. This is sort of like these like mind body studies that have been done that have shown that, right? So just wanted to add that. That's pretty fascinating.
Yes, yeah, it is.
I was thinking about, as you were talking, so you're really getting at the root cause. You're trying to get at the root cause of things and treat that, and not just, cover it up with Band-Aids. So we have these GLP-1s now, and I'm curious if you would share your thoughts on those, and especially in older adults. Now, I know every age now, is using them, but maybe we could focus on older adults. Who really are these for? I mean, they have different indications at this point, and I'd love to hear maybe some of the downsides too, or the people that maybe shouldn't be using those. I'll stop and hear your answer to that.
Yes, thank you. That's the hot topic, hot medication. So we recently, with my, again, medical students, we recently created a handout because even they don't realize that GLP-1 medication, the first one was approved in 2005. So it's not a new medication. So we're really not having our patients or human beings become guinea pigs, since these meds have been out in media for last few years that they become the talk of the every show or every newspaper or every newsletter. But, GLP-1 is actually a hormone, and we usually have a very short half-life for these hormones. So say we all have them and they're produced in our gut and our intestines. And they usually get stimulated or they appear in the blood circulation after we've started eating. And they just stimulate this action of improving our blood glucose by affecting the insulin, by affecting the pancreas, as well as our glucose ice. And then they disappear within 4 minutes or so. 2 to 4 minutes is what their life is. And when we humans discovered this in the form of a medication, they created it in such a way that it's longer lasting, so that it could benefit patients with type 2 diabetes mellitus in a positive manner. So that's the first reason for its approval in 2005 for type 2 diabetes mellitus. When behold, as the physicians endocrinologists started using it for type 2 diabetes mellitus, they noticed that there is a great amount of weight loss that's also contributing to their improvement in blood sugars, other than the direct effect of improvement in blood sugars. And within few years, they got FDA approved for treatment of obesity. And now coming to 2025, we have multiple kinds of these medications. There is a combination of GLP-1 and GIP, which is tirzepatide, known in the form of Mounjaro and Zepbound. So now we have more indications other than type 2 diabetes mellitus and obesity. Also recently approved for treatment of sleep apnea, which is moderate to severe. There are studies. I think there's only one study, to my knowledge, for Alzheimer's, like prevention of dementia. And we have great data that when patients with diabetes mellitus have used GLP-1, because there is improvement in so many parameters, including the weight, the risk of cognitive decline has either paused or it's been delayed, or it's there has been improvement in the cognition, right? But we only have data which is related to metabolic. So either the medication was used to treat obesity or to treat type 2 diabetes mellitus, where you also see positive changes, improvements in their brain health, reduction of cardiovascular disease or heart disease. In general, if you're talking about elderly patients, right? So if they've never been on it, and I would define an elderly patient also based on their mental, physical capacity and how young they are at that age. So it could be an 80-year-old, very functional, physically independent, but say dealing with type 2 diabetes mellitus, which is causing a havoc in their health. And if someone's thinking about that, this could be the right medication, that is GLP, you also have to think about that these individuals are more prone to constipation. Again, our gut slows down, age related, we have constipation. So will this patient be a good candidate for it? The second thing is, avoiding multiple medications for diabetes in elderly and introducing GLP-1, because they will have a higher risk of low blood sugars, hypoglycemia. So it has to be individualized based on, am I causing polypharmacy side effects here? And if it's going to benefit the individual, then can I possibly think about the lowest dose? Can I eliminate certain medications which can cause similar effects and a negative side effect in that particular individual? The other aspect is also, nausea is pretty common when these individuals start. So if it's an elderly patient, I usually will have a discussion with their primary care physician, or if they have other physicians in his or her health care, as to if they are on antidepressants or if they have some psychiatric disorders that negatively impact this patient. So this has to be very individualized. And if they have any form of metabolic conditions, which we talked about, And if it's going to be beneficial, then I would really cater it towards that patient, knowing that I am eliminating these factors and also making sure that these patients are not dealing with nausea and constipation, worsening of constipation, because constipation untreated, it leads to hospitalization. Nursing home patients, that's one of the reasons for, infection or altered mental status because they're constipated for so long. Yeah.
Yeah.
So all in all, if in the right hands, the right person, right patient, right candidate, it could be beneficial because you're reducing their metabolic risk factors, but also knowing, being very aware that how I'm going to cope with the side effects for that particular patient.
Thank you. And I'll just mention that. So the studies that are being done right now, the phase 3 with semaglutide, in individuals with the early symptomatic stages of Alzheimer's disease, I believe that will read out next year
Mm-hmm.
if that's going to help with
Yeah,
the cognitive decline. So
that's
we'll see. We don't know yet. Yeah.
And that's only for patients for dementia. They're not even including type 2 diabetes, mellitus, or obesity, right?
They can have that. Yeah. As long as have an endocrinologist that's working with them to make sure they're,
Yeah, so there are not just one exciting
yeah.
benefits of GLP-1 in different aspects of our health as we learn more and more.
Well, that's a perfect segue. Maybe my last question is about as you continue doing all of the things you're doing with your practice and teaching and podcasting, what future developments in your fields in endocrinology, lifestyle medicine are you most excited to share with your community?
Yes, prevention. Oh, I feel like our younger and younger generation, they are just becoming more aware.
Mm.
The individuals that I see between, say, 50 or 40 to 55, because they're seeing their aging parents or dealing with multiple conditions, medical conditions, they have become even more proactive
Mhm.
to take measures now as opposed to just wait till they get to 75, 80, or break a hip or lose memory and then get evaluated. So that's what I'm excited about, that there is more prevention in terms of knowledge, understanding, and the resources that we have. And for younger individuals, I see our younger physicians in training and medical students, they have become more and more in tuned with how I can learn about prevention, lifestyle interventions, counseling my patients about that rather than
Mhm.
just learning the pharmacological world of medicine and science. So that makes me very
Absolutely.
excited about it. And with future developments, the hormonal world for menopause hormonal therapy, I'm so excited that, women are
Just
stepping up, physicians are
froze.
stepping up to teach us. And at the same time, our the GLP-1 that we talked about, we've had great introduction
Let's see.
of these medications in different fields. And I'm pretty sure we'll benefit when it gets to the right physician and the right patient, and we're using it for the right indications, knowing was the introduction of menopause hormone therapy in women speaking out loud, and physicians also
Right.
encouraging the right
Mhm.
indications and the safety for these medications, as well as men stepping up to learn about their health and also, cut the noise by looking for new proper resources. And the GLP-1 world, yes, we've had a more diversification in terms of obesity, diabetes, but also coming out in different specialties, rheumatology, pulmonology, neurology, where hopefully we'll be able to prevent diseases sooner than later in our younger generation. So prevention is what all I'm excited about that we're working towards in science.
That's so encouraging. And knowledge is power. So go young people who are, being willing to be honest with themselves and try to stay healthy from a young age. So maybe you can share, Dr. Makija, where can people find you if they want to become a patient, if they want to do any programs with you? Where do we find you?
Yes. You can find me on my website. It's unifiedendocrinecare.com. And I have my podcast, Hormones and Hope, on all the channels, including YouTube, my Instagram, Facebook. They're my name at Chhaya Makhija MD. I would love to see you or, connect with us. I have newsletters, so you can sign up, get free downloads on GLP-1, osteoporosis, diabetes, and get yourself educated and pass it along. And
Thank
thank
you.
you
Wonderful.
for letting me share that.
She has tons of resources there on her website. So please check it out. Well, thank you again. You've given us so much knowledge. I'm so excited for our listeners to learn from you. Thank you for your time.
Thank you, Dr. Cabral. This was fun. I love your podcast.
Same. All right, listeners. Well, thank you again for joining us. If you're listening on the podcast platforms, please rate and review. And on YouTube, please like and subscribe and leave comments. It's going to help us learn about what's going well and what else we can add to stay resilient. Thank you, everybody. Have a great day.